Welcome to Health and Veritas. I'm Harlan Krumholtz.
And I'm Howie Foreman. We're physicians and professors at Yale University. We're trying to get closer to the truth about health and healthcare. Our guest today is Dr. Vanessa Cooper. But first, we're going to check in on hot topics in health and healthcare. And Harlan, sometimes you and I talk in advance and you tell me what you're going to cover today. It is open-ended.
I was debating, so I have two quick things here today I wanted to talk to you about. But one, I wanted to reflect on, we're recording this on the first day of the government shutdown. How, as you know, that this will come out tomorrow. Maybe if we're lucky, it won't continue, but people will be listening to this. It'll be at least the second day.
Yes.
And you're going to talk a little bit about some of the issues in the latter part of the show. But I wonder what you think about this. You know, as I was reflecting on this brinksmanship that's going on in this country, listening to Pete Hegseth talk to the generals yesterday, you know, I just had this sense that we've entered this stage where it's winners and losers. You know, there's not about negotiation or compromise. It's really about a zero-sum game and one group winning. I mean, they may gesture at the idea that they want to negotiate, but in the end, you know, this is where we are today. You know, it's like very different worldviews and a sense that, you know, you need to win. You need to win. And so I think that's what sort of put us in this predicament. And, you know, both sides are going to need to appeal to voters and try to get more than what we've got, which is a standoff. And when we have a standoff, we just cannot progress as a country.
I agree. And, you know, we only have meaningful elections every 2 years, but we do have an election coming up this year that's less significant in parts of the country. But there are some states that are in play for governorships, and there's some special elections. And it may give us some signal whether voters are as disenchanted as I think they are with our Congress and our elected leaders, and try to force them to be a little bit more collegial, conciliatory, and collaborative.
You know, our friend Ruth Katz would tell us that when she was in the, you know, working as a staffer in Congress, you know, now maybe 30 years ago, that there were a lot more conversations trying to broker deals and reach some level of compromise. I don't know whether that's the fog of history, you know, that really.
No, there's no question that Orrin Hatch and Henry Waxman and Ted Kennedy.
That they would broker deals.
That's right.
They would broker deals. I mean, that's the whole idea of the Senate. This idea of the 60 votes was that it was going to force them together. But we have to stop this brinksmanship. It's just not good. And we are a health podcast, but I'll say that all this intersects with health, as you're going to talk about.
Sure does.
Later in the show. So the other thing I wanted to mention is an editorial that I wrote this week for Jack. You know, I get the opportunity. I'm actually doing this weekly now, putting out editors' pages on different topics.
How you do all the stuff you do.
Well, the title this week was Tools, Not Ghosts: Artificial Intelligence, Writing, and Responsibility. And I took on this idea about what should we be telling authors about their use of artificial intelligence. And here I'm not talking about AI. Of course, there's lots of nefarious ways that AI can be used in fabricating research or papers without human engagement. I'm not talking about that. I'm talking about when authors are saying, I need to improve my writing. And so I want to use AI as a tool to help me express these ideas more clearly. And what I had detected was that there had been a stigmatization of authors using artificial intelligence, even to the point where I heard one of my editors say, gosh, this is coming from X place and it's written too well. They must have used AI, as if that was a problem.
Right.
And a lot of the journals were in a position where they were saying, well, if you use AI, you need to disclose its use. And I wanted to come out, and the Jack journals writ large, are 10 of them, you know, we're all together on this, wanted to come out and say, hey, use it. I want you to use everything possible. You guys use spell checkers.
And you guys are going to edit the manuscript in the end anyway. So there's always.
I want it to be as well written as possible. It's just, it needs to be your work. Right. So the point was to encourage people to use whatever you can. I mean, you know, whether that's a human editor, whether it's a AI editor, you know, we need to be able to take advantage of these tools, but that doesn't mean you can delegate the responsibility. If something's wrong, if something's plagiarized, if something is incorrect, you're not going to be able to say, well, that was AI. That's you. You've got to take that responsibility. And I only tell people, AI right now, it's like an instrument you need to learn to play. You cannot yield to it. Automation bias, where you basically just truck it over, is something that really will get you in trouble. That it is not so expert that you can't know that it may have plagiarized, it may have misrepresented. There's lots of things it can do, but
Right.
it can help as an editor. And I want to say, as an editor of a journal, I think we're one of the we may be the first journal that's come out and said, use the tools,
Yeah.
absolutely, but just use them responsibly and take responsibility. To suggest otherwise, you're putting authors in a place where they're going to be forced to mislead or.
Yeah, I admire that you're taking that leadership role. Like, you are somebody who has an enormous body of work that you've contributed to, and you're the editor of this large set of journals. And when you speak about these topics, it'll have an impact. And I think it's really a positive leadership role for you.
Well, I think it's a matter of recognizing the inevitability of these tools. They're ubiquitous now, and people, to be top authors now, then you need to be able to use these tools. Just like I say, if you want to be a top athlete today, you need to be using AI, you need to be using a whole range of tools that will help you make sure that you're developing the skills you need. But ultimately, that athlete's the one performing. That's why the author's the one who's performing, but they should be using whatever tools they can to help them.
Well said.
Yeah. So we'll see. So far, it's gotten a good reception. We'll see. We'll see how it plays. A lot of old school folks,
I bet,
who don't want to see this happen. But like I said, I think they're up against an arc of history. Hey, let's get to our guest today. She's going to be terrific.
Dr. Vanessa Cooper is a neurologist and assistant professor of neurology at the Yale School of Medicine. She serves as a longitudinal coach for Yale medical students and is the associate director of collaborative excellence education for the neurology department and the residency program. Dr. Cooper specializes in headache medicine and provides outpatient care for individuals with chronic headaches. Dr. Cooper received her bachelor's degree in chemistry and sociology from Stony Brook University, and then earned her medical degree from New York Medical College. Subsequent to that, she completed her internship, her neurology residency, and a headache fellowship at Yale New Haven Hospital. And so we welcome you to the podcast. We do not spend enough time talking about some of the most common medical ailments that afflict each of us. And Harlan and I both have our own personal experiences with headaches. And quite frankly, when I see statistics that say 50% of people have a headache in the past year, I'm shocked, because I would have thought it's 100%. I think headaches are one of the most common things that I hear from people. And so I'm so glad to have you on. And I wonder if you could just start off by telling us a little bit about what drew you to headaches in particular, given that you start off in a neurology orientation.
Yeah, so thank you so much for having me. So one, headaches, migraines in particular, are very complex. And often it is an invisible illness. And because of that, there's a lot of stigma. It primarily affects women, certain headache disorders. And because of that, like I said, a lot of stigma around it. And I wanted to really get involved as far as advocacy for my patients. And within the last 5 to 10 years, there's been a lot of research, a lot of new treatment options where we're able to make a difference and decrease disability. So that's kind of what drew me towards headaches and migraines in particular.
And just one quick follow-up for our listeners. Like, to me, in the ER, I'm doing a lot of head CTs for headaches. And for the most part, they're looking for, I think, what are called secondary causes of headaches, like structural problems in the brain, which are very uncommon, but nonetheless are either treatable or at least something that requires a different type of treatment. Can you just quickly say, just for our listeners, what should people be thinking about if they get a really bad headache? What should cause them to have concern?
If it's the worst headache of your life, meaning you've never experienced headache pain like this before, that would be something I would seek immediate emergency attention for. Other red flags include if the onset of the head pain is very fast or sudden onset. So you're having maximal intensity of pain within 1 minute. That can mean a secondary headache, such as a brain bleed in particular. Other red flags to look out for if it's a new headache, but it also comes with significant fever or other neurological conditions with it. So a headache, but you're also having visual changes. You're having weakness on one side of your body. You're having difficulty speaking or understanding, or any type of sensory changes on any side of your body. Those would be things that I would seek emergency care for.
First of all, it's a delight to have you on the program. And the issue of headache is so interesting to me. I'm a cardiologist, and it has certain parallels because the truth is that there are a lot of people that have what you just described. They have rapid onset, it's a severe headache, and it's actually ends up being nothing. Just like there's a whole bunch of people who feel chest discomfort. Now, what we see as cardiologists is the people come in with a heart attack who waited too long. But if we start saying every single person who has any sort of discomfort from, the bottom of their jaw to the sort of top of their stomach, or, in any way their shoulders are going down their arms, should be running to the emergency department, we'll be overrun with people who don't need to be evaluated. And that ends up being a hard problem because if we over-index on the person we know who had the disaster, in the case of headaches, the person who ended up having a bleed or a brain tumor, then, we'll end up having massive numbers of people come in for evaluation who don't need to. And it becomes really hard to discriminate. And on one hand, we don't want to give false assurance to people like, don't worry, stay home. It probably is nothing, which, by the way, on average, it will probably be nothing because we don't want to miss the catastrophic stuff where early intervention will make a difference. As you've thought about this, because on the show, we can say those sort of high level things, if it's the worst headache of your life and so forth, but is the field working towards better, tools that can help people to make that sort of determination, like this is something I really need to be seen for, so we don't miss anyone with important conditions?
Yeah, I think one of the most helpful things is really getting a patient that has a history of headaches established with a headache specialist or neurologist. Because that way, one, they develop a relationship with this person who knows their pattern. And a lot of headache patients, especially migraine patients, that they are really in tune with their body. So they will know if it's a regular headache attack that has an aura. So aura will have, reversible neurological symptoms. They'll have the vision changes sometimes. They'll have the difficulties with speech. However, if it's lingering on and if it's lingering on and it's more than that 1 hour, which we usually say if it's an aura, it should last up to an hour, it can last more. But if it's more than you normally are used to, that's when they should seek care. As far as specific tools to determine who should go to the emergency department and who shouldn't, I don't think we're there yet. I think a lot of it is, like you said, we don't want to miss the catastrophic things. And I know it's very cliche, but essentially, worst headache of your life, they should definitely seek emergency care. As far as new neurological symptoms, it's going to be hard pressed to say, maybe it's nothing, especially if they're having their first aura, they're not familiar with it. So we actually still encourage patients to still go to emergency room, just because if it does happen to be a stroke, we can do interventions for those things.
Given the number of people, at least what do we say, Howie? You said 50% of people, like there's this enormous, maybe greater number of people who've got headaches. Are there enough of you guys, enough of you headache specialists to be able to handle? How long does it take to see you now if I try to make an appointment?
6 months.
Wow. We got somebody here who I feel like we're good. We got on our calendar.
I know. We should get on now.
How are we going to solve that?
Great question. So there are not a lot of headache specialists. I think what has happened to neurology in the last decade is that a lot of neurologists are no longer general neurologists, right? So general neurologists, very comfortable with seeing patients with headache. They kind of take care of all subspecialties within neurology, but now everyone has subspecialized, meaning we now have, experts in epilepsy, movement disorders, multiple sclerosis, neuro-oncology, and now headache. And now everyone is branched off. And unfortunately, not that many neurologists, when they're graduating from residency, are going into headache medicine. I would say on average from our department, maybe 1 or 2 per year. So about 10% or less. So definitely not a lot of headache specialists. And there are actually 2 states, I think, in the United States that have actually no headache providers. And we cover that in our annual meetings on how to bridge those gaps.
Wow. With regard to lifestyle, are there recommendations that you can make to people that are known to help reduce the frequency and intensity of different types of headaches? I mean, is there a lifestyle component here, and can people be encouraged in that way?
100%. So I think a big thing is consistency. So the migraine brain or the headache brain in general really likes consistency. So consistent sleep schedule, making sure that you're going to bed at a consistent time every night, waking up at this, a consistent time in the morning, and really aiming for 8 to 9 hours of sleep a night is a huge one.
How many hours of sleep a
8 to 9.
I mean, Howie's the only person I know who gets 8 to 9 hours a night.
I do. I rarely get 8 to 9, but I do aim for 8 to 9.
Hydration is a huge one as well. Dehydration is a known trigger in some patients, so really want to aim for more than 64 fluid ounces of water a day. Not overly caffeinating. So some patients will say, caffeine helps their headaches, helps during a migraine attack, which is true. Caffeine does have an analgesic effect. However, too much caffeine can be a trigger. So definitely want to limit to less than 200 milligrams of caffeine a day. And then exercise is a big one. Being physically active helps to minimize the frequency of headache attacks. So that's one that we really try to tell our patients. So sleep, hydration, caffeine, exercise, and then not skipping meals. So being on a consistent eating schedule, sometimes, skipping meals can definitely be a trigger or increased risk of having a headache on a certain day.
Yeah, these disruptions in circadian rhythm really are associated with headaches too, right? It's like just what you're saying, consistency is so important.
Yep, very important.
What is the typical makeup of your patients? Is it mostly people that have ongoing migraines, or is it mostly people that have post-concussive? What is the mix that you see?
Yeah, I would say the mix. Majority of my patients have chronic migraine, meaning they average about 15 days or more per month of headache in general.
Wow.
So I would say majority is chronic migraine. The second commonest, I think, would be episodic migraine, meaning anywhere between 1 to 8, 10 migraines per month. And then after that, I would say post-concussive is pretty common. A lot of patients, they have car accidents, some type of head trauma, fall. And then there are more rare types of headaches. So we, see cluster headaches, trigeminal neuralgia, which is this very specific type of facial pain disorder.
So I have this, since we've got you here, and it would take me 6 months to see you, I might as well take advantage of the consult. So from time to time, I get just the aura, no headache, and it will last for like 20 minutes or so. What's happening physiologically? So just for people who are listening who are fortunate enough not to have this, my vision is obscured. So it mostly on the periphery, and it's sort of scintillating aura at the periphery. But sometimes it can go more towards the center, and it's just bothersome. I mean, it's hard to see. I can see, but it's bothersome. I don't have a big headache, but I'm just kind of wondering, like, what's causing that?
Yeah. So the pathophysiology. So just to back up, so about 20 to 25% of people that do have migraine will have an aura. And the most common type of aura is, like you described, the visual aura. And the second most common is a sensory aura. And it's not uncommon that patients may actually have two different types of aura at the same time.
And what's the sensory aura? How would that manifest?
Yeah, so that manifests usually as a loss or a tingling. So they'll mostly will describe like one half of their face becomes like numb and tingling. And then sometimes it'll spread down to their arm and then also can spread down to their leg. And patients that have had the sensory aura, they typically will say they have the visual aura first. And then all of a sudden they notice that their face kind of feels weird. And then they notice like a spreading down of that sensation, spreading down to their arms or their legs. I forgot your question already.
So what's causing, like, what's happening at the level of the biology that's causing that?
So there's like a depolarization wave essentially that is going across the cortex. And that's kind of what we know to cause aura. A little similar to seizures. So in particular in patients that only have aura, seizure medications actually have shown to be effective because of that depolarization wave that goes along the cortex. Anticonvulsive medications can kind of shut down that pathway and minimize auras in some patients.
When I was younger and I had more classical migraines, I don't remember if they're called classic migraines, but the aura followed by the headache, I would have like hemi-neglect of a type of a visual neglect that would occur for the rest of the day, where I would react slower to things on one side of my body. If someone threw me something on one side, I would like almost ignore it. Whereas if you threw it on the other side, I would notice it. And I'm fascinated by the same thing Harlan's saying, is like how utterly complicated it is. I'm more impressed by the fact that we've made so much progress now. There are really medications available to be able to proactively, preventatively treat migraines in so many people. How successful are those? And can you give us some sense of the categories that they're in?
Yeah. So the biggest, like the hot thing right now are the CGRP. So calcitonin gene receptor peptide, monoclonal antibodies, which are used for prevention. And then we also have the antagonists for acute therapy or as needed therapy. So what we do know is that when a patient is having a headache or migraine attack, the CGRP molecule increases in the bloodstream. So what the preventative medications or the monoclonal antibodies do is that they target the actual molecule or the receptor of CGRP and prevents it essentially from binding. So that will minimize headache frequency as well as severity in patients. And then the same thing goes for as needed therapy, prevents the molecule from binding. And that has been like all the rave right now within the headache field. We've had several medications that have come out within this newer class. And it's actually the first class within the last 10 years, well, ever in history, the first class, which is migraine specific. Historically, before these medications, all medications used for migraine prevention were of different categories. So blood pressure medications, anticonvulsants, etc.
And just to speak one more thing about biomarkers, because I didn't even realize that you have a specific biomarker that can be measured. Are we testing people for that when they're having a migraine? Like, is that a diagnostic test, or is that just used in terms of developing the drug?
Yeah. We only, from what I understand, we only use this for research. As far as a diagnosis of migraine is strictly clinical, and any headache disorders is strictly a clinical diagnosis.
These advances are terrific. One thing I have to ask you though is how much does it cost, and are people able to get them? There's so many people suffering. I worry that sometimes we have these great new things to be used and help, but is there any issue here with people getting access to them?
It's a huge issue. um, these medications are very expensive. So the preventative medications, the monoclonal antibodies, you get one injection per month. That will run you about $1,000 to $2,000 per month just for that one injection. And think they're using it chronically, so this is probably going to be on it for a lifetime or a lot, plenty of years. A lot of insurances will require that a patient try non-specific headache medications before they will even approve it. So there's like another step we have to do prior authorization for all of these medications, which makes it extremely difficult for patients to get. And then once they do get it approved, the copay is astronomical. Thankfully, a lot of the companies do have patient assistant programs and copay savings cards that do bring the cost down for the patients. So we've been able to utilize that. Unfortunately, for patients on Medicare, which I've seen the biggest issue, they cannot use any of the copay savings cards. So essentially, we have a subset of population of patients that are unable to really get access to these medicines.
Yeah, that's a real big problem in the at least short run. Hopefully in the long run, you can have broader availability for individuals. How effective are they?
So very effective. So as far as numbers go, majority of the monoclonal antibody, I'm just going to ballpark. So a patient will have close to a 50% chance of minimizing or decreasing their headache days by 50%. So, if they're having 30 days per month of headache, they have about a 50% chance of reducing it to 15 days or less per month, which in the research world compared to other headache medications is really great.
Yeah.
One thing I wanted to pivot to, which I think is kind of an exciting area, is these neuromodulation devices. Mm-hmm. So remote electrical neuromodulation, transcranial magnetic stimulation, these vagus nerve stimulation. I mean, this sounds like science fiction, that you can actually be using electricity. Can you just explain to people listening, where's this field moving? How does it work?
Yeah.
And are you using this?
Yes. So I think neuromodulation is great, especially in this day and age. A lot of patients will say they don't want to take medication. They're, really wary about pills and side effects. So neuromodulation devices are a great avenue for them to explore. We do have several neuromodulation devices, some that target specifically the trigeminal nerve. We have remote electrical neurostimulation, which is an armband. And then we have, occipital nerve stimulators, et cetera. And then, like you said, vagus nerve stimulators. So we have several devices that help minimize migraine frequency and help during attacks of migraines. The biggest thing is cost. Insurance does not cover neuromodulation devices.
And so give us a sense of how this works. So you come in the office. I mean, is it in the office? Can you do it at
No,
home? Or
so they do it at home. So a lot of these medications, they can just order it online. They just Google it. They can order it online. They'll ship it to the patient and they use it at home. So
And how can you be sure it's a credible device versus someone trying to scam you?
So we have there's very specific neuromodulation devices that we know are FDA cleared. So Cephaly is one of them. So this is an external trigeminal nerve stimulator. They can go to the Cephaly website and order that directly from their website. That one will run patients around $500 for the device. Again, not covered by insurance. Another popular one is GammaCore or Truvaga. Truvaga is the vagus nerve stimulator where patients, they put a device to the vagus nerve, and all of the websites.
And what does it feel like when you put it on?
It's kind of like so the vagus nerve stimulator kind of feels like a slight vibration. And then patients will have like a pulling of the.
And it's giving electrical pulses. I mean, that's what is
Correct.
it doing?
So the Cephaly device is a external trigeminal nerve stimulator. So patients put it on their forehead to stimulate very specific branches of the trigeminal nerve. And that stimulation helps to minimize trigeminal nerve pain. The same thing with like the vagus nerve stimulator. And I think it's really cool, the remote electrical nerve stimulator. It kind of works like a TENS unit. Patients will put this armband on their arm and it works in some way to minimize head pain. A lot of it also is biofeedback. So with the Nerivio device, which is the remote electrical nerve stimulator on the arm, they run a program on their phone. And while they're running their program on their phone, it's taking them through biofeedback exercises. So I think a lot of that, if you believe it's going to work, it may work for you.
But are there randomized trials that are seemingly well structured that show that it does work in some people?
They are trials that shows that it works, but I'm unsure if it's that much better than placebo.
Okay, so you're not fully convinced about this. Since you told us that it'll take 6 months to see a headache specialist in our area here, as a final question, at least from me, like what can we do to expand the primary care workforce's capability in the headache space so that primary care doctors or whoever else is out there could help patients get treatment earlier?
So the American Headache Association or Society, the AHS, American Headache Society, they actually have a great primary care program specifically to teach pearls and tools or like a workflow on how to manage a patient with headache disorders, specifically migraine. And they have, really short bits on their website as far as workup, tools, medications to start patients on while they wait for headache providers, and even how to prescribe the new novel medical migraine medications that are available. So I do think, educating our, primary care providers to kind of get the ball rolling with the headache treatment will go a long way. Because at least if they start some treatment before they get to us, it makes the job easier to prescribe the newer medications to the patient.
It's great. I can't thank you enough for joining us and talking to us about this. This is like one of these topics that I continue to come back to for myself and for others all the time. And it's great to know that we have a headache center here at Yale and that you're working in it. It's great to have you as a colleague. So thank you.
You deserve a 6-month wait list. You deserve a 1-year wait list. And I'm glad I was able to jump the queue today
That's right.
in the podcast.
That's right.
Anytime. Thank you so much for having me.
Thank you.
Well, that was a terrific interview. Thank you for bringing Vanessa Cooper on. Yeah, she's really smart, great, articulate. But look, you are going to get into some of these nuances about what's going on with the government shutdown and help explain it to the listeners. What is this issue about these credits and so forth?
Right. So it's not the first time that we're even talking about this. We just did it a few weeks ago. And as you said at the beginning, the government is in some phase of shutdown right now. It doesn't happen all at once. And if this lasts longer, people will start to feel it. But in the first few days, it's a minor nuisance at best. But it's all about Congress not agreeing on appropriations for all of the executive branch parts. One of the key sticking points that Democrats have made an issue is whether our government continues to provide extra subsidies on the Obamacare or ACA exchange. I want to better explain that because I think this sounds too wonkish for people. As our listeners know, nearly 70 million people are on Medicare, nearly 80 million are on Medicaid. Some of these are double counted because people are on both. And about 150 million people get their healthcare insurance through their employer or a family member's employer. Those who aren't poor, disabled, elderly, or work for a large employer are often at the whims of a market that has not been really accommodating. So there are roughly 24 million people who get insurance through these so-called Obamacare exchanges. Now, initially, policymakers hoped that the so-called mandate tax, or the mandate that Obamacare had written in 2010, would force people to get this insurance, but that was completely undone in 2017. And the main thing that makes this market work at all are large financial incentives for lower income individuals. And what do I mean by work? What I mean is that if you were to allow people to choose whether to be insured or not, those who are the healthiest among us might logically choose not to buy health insurance because they might perceive that it's not worth it for them. And the remaining people would be forced to share ever higher costs. And we've proven this time and time again. And health insurance becomes unaffordable if healthy people don't buy health insurance. If you force everybody into the pool, which is not easy, then you have perfect spreading of risk, and it absolutely is more affordable for everybody, and particularly the higher cost individuals. As I said, the mandate tax was not a strong incentive, but it did help, but it's gone. Income tax credits or financial incentives do help a lot. The lowest income individuals have been able to buy policies on the exchanges, oftentimes with zero of their own dollars, so they contribute nothing, even though those policies might have high deductibles. And those individuals would then have a health insurance policy. Now, those people are not poor enough to qualify for Medicaid, but they are poor. But the credits themselves phase out at 400% of the federal poverty level. And just for our listeners, that equates to about $62,000 for an individual. So what most people would equate with lower middle class right now. And thus many middle income and higher income individuals would not qualify for those incentives. So enter these so-called enhanced premium tax credit subsidies. These were brought about with COVID in the American Rescue Plan of 2021. And then they were renewed with the Inflation Reduction Act, and they expire December 31st of this year. They have been wildly successful. Enrollment on the exchanges has doubled. It was 12 million before, it's over 24 million now. These credits help even many higher income individuals. And you might say, and logically, I don't think it's wrong to ask, why should the taxpayer be subsidizing the health insurance of higher income individuals? It's a good question, but the answer is an easy one. We already subsidize health insurance purchased by everyone else. We substantially subsidize employer-sponsored health insurance. We obviously subsidize Medicaid and Medicare, and we also subsidize military and veterans benefits. The only group we have not explicitly subsidized are these individually purchased health insurance products until the passage of the ACA. And now with these credits, we extend that subsidy up a little bit higher, and they're also bigger subsidies. It's a long way of saying that these enhanced premium tax credits that Democrats are fighting for right now are working as intended, and we can ill afford to watch them expire this year or next. It's going to cost about $35 billion a year, so it's not a small amount, but it's certainly not in the range of the trillions of dollars involved in the recent tax cut bill that was passed in early July. So I'm eagerly watching to see this resolved, not just for the coming year, but for the foreseeable future. And I think all of us should look out and try to better understand why Democrats feel this is a hill to die for and why Republicans, I think some in good faith, say, let's discuss this, but we don't have to do it right this minute when the entire government is at risk.
I want to try something here with you. If you are a Republican spokesperson right now and you are making the case for why you're not extending those right now, why you're saying like, hey, let's do a continuing resolution. It's a clean continuation bill, and let's now negotiate this separately or deal with it. And you're a Republican spokesperson right now. What's your case for this? I mean, isn't there another case that can be made?
I think that if I were speaking on behalf of a member, I would say exactly what you said. But I think a lot of people know that even if you get members to speak out right now that they want to make this happen, when push comes to shove, it may not happen. And very importantly, the rates on the exchanges for January are set now. The exchanges will open up in a few weeks for people to buy policies for next January. And if they see their rates going up by 75%, which is the average rate increase that we expect about 4 million fewer people to buy policies. Now is the time you have to act.
But what's the case for this isn't what we should be doing? Because as I think about this, and the part that I don't quite understand is, I think this will disproportionately hurt people in red states. I mean, it will hurt people across the country, but in terms of people who are vulnerable,
yes,
just
You're
given
correct.
the socioeconomic standing across the country and so
and
forth.
the types of people that are on the exchanges, they tend to be small business owners. They tend to be working for small businesses.
So what's the case for saying that we should either let this lapse or we need to change this because it's not working? I mean, it just seems to me like it's what they might in other situations be fighting for.
Yeah. So if I were trying to navigate this and just do what's right for the country and not necessarily political considerations, there are things you could do better. There are some people out there who believe that some of the policies that are being encouraged, $0 policies, are basically making insurance companies money. We should be minimizing that. We should be tweaking it. We should always be tweaking things. We should be making them better. That's not what's seemingly in play right now. And by the way, if you wanted a good faith effort, I personally, if I were the Democrats, I would accept a 1-year extension now. I realize politically that might not be smart, but a 1-year extension of this would be a really good faith effort to say, we can make this better. We're going to start working on it tomorrow. But for now, we're going to make sure next year is going to work.
I see. And I do think that maybe part of this is it gets tied to this tag Obamacare. And there still are people who just really want to overturn Obamacare. Well, that was a really good explanation. Thank you, Howie.
Thanks, Harlan.
You've been listening to Health and Veritas with Harlan Krumholtz and Howie Foreman.
So how did we do? To give us your feedback or to keep the conversation going, email us at health.veritas@yale.edu or follow us on any social media.
And give us feedback. We got some feedback this week from some folks, some that we had mentioned on previous podcasts, so we really enjoyed that. But yeah, give us feedback, rate us. It's all good.
And by the way, we talked about headaches today. If there's a favorite, maybe favorite's not the right word, but if there's a condition you want to hear us talk about, email us or post it on social media. We'll find somebody to talk about it. We really want to meet your needs. If you have questions about the MBA for Executives program at the Yale School of Management, reach out via email for more information or check out our website at som.yale.edu/EMBA.
Health and Veritas is sponsored by the Yale School of Management, the Yale School of Public Health. We're fortunate to have some superstar undergraduates working with us, Gloria Beck, Tobias Liu. We have a remarkable producer, Miranda Schaefer, and I have the best co-host in the world, Howie Foreman.
Right back at you, Harlan. Thanks very much. Talk to you soon.
Talk to you soon, Howie. It's great to see you.